who are ambulatory, mobile ambulatory, and their care needs do not exceed the capability of the home. Okay? So they can walk or they're in a wheelchair, but they have such a high level of healthcare needs that they're out of their level of care in your facility. And it could be because, let's say, personal care homes do not require any healthcare qualified individuals to work in. So let's say that you're one of these personal care homes and you don't have a nurse or you don't have a CMT or you don't have anybody that has a healthcare certification or license, yet you've admitted somebody that requires actual licensed healthcare from a licensed healthcare professional. That's inappropriate. Okay? Now that doesn't mean that somebody may need healthcare that you can admit to your facility and that you can obtain that healthcare if they meet the definitions, which we talked about earlier, but then they have healthcare needs that, for example, let's say that you have home health coming in who's providing maybe a wound care for this individual. They've had a surgical procedure, they have some wound care that needs to be done. This person needs that care. They contracted with home health, they're coming in, they're providing it. This person is still meets the definitions of a personal care home resident, okay? They can be in personal care. So we're going to talk about that a little bit more, about what the facility's responsibility for supervision, and I'm going to go ahead and say this now. You're still responsible for that person, okay? You've taken on the responsibility for supervision and meeting their healthcare needs, so that's the way it is. Even though you may contract with another entity to come in, they're actually your contract with that person. So you're still the primary person that, when Samantha comes in, she's going to be focusing on you and on you saying, okay, this is your facility. This is the person you said you would take care of. You can't say, well, I don't know, home health did that. That don't work. Okay. It's the same thing. Your staff can't say, well, I don't know. I know home health comes in and does something, but I don't know exactly what it was. And yeah, I saw her bleeding, and I figured, well, home health will take care of that when they come in. That doesn't work. That your staff needs to understand what home health's doing. Everybody needs to be on the same page and working together. Okay. Admissions. A personal care home shall not care or be responsible for the care of more residents than their capacity. Okay? So you can't tell me that we have a bed capacity, our CON says we can have 90 beds and we have 91 residents. Well, she's leaving on Saturday, so we went ahead and admitted her because there was no one else to take care of her. You're over your capacity. So now, if Jane's walking out the front door and Mary's coming in the front door, you're okay. But you can't have Jane still there when Mary comes in. So, and I think that's pretty clear. In fact, I don't know that I've ever really admitted that.
By the way, CON is Certificate of Need.
Oh, I'm sorry.
And for all licensed personal care homes, you must have a certificate of need prior to even becoming a licensed entity. Okay, so just so you know what CON is. So basically what he's saying is if you're licensed for 80 beds personal care home, you're not to exceed 80 beds, 80 residents within your personal care home.
And be careful with that if your personal care home is attached to a skilled unit. That's one of the things that sometimes people want to play with the numbers, and I don't think it's to get over anybody. I think it's usually because you're trying to meet the needs of a resident. But it's, remember, at any given day, think about your census. How many residents do you have? How many beds? And if you have more residents than what's on your license hanging on that wall, there's a problem. There's a big problem. Now, a person can go to your skilled, let's say they're in the same building, and because they've had the flu or they've had some sort of healthcare situation that takes them temporarily out of being a personal care home resident, and maybe they're in a skilled unit. But the plans are for them to come back to personal care. That happens quite a bit. But you can't play games with saying, well, this person's going to skilled, and while we're waiting for a skilled bed to open, we're going to put them in personal care, and now we're over our capacity of personal care, and then tell me, oh, well, don't worry about it. They're only going to be here another 4 days till we get them in that skilled bed. Can't do that. And I think everybody knows that. That's not rocket science. Basically, upon admission, a resident responsible member of their family or committee shall be informed in writing of policies of this facility, and they have to include fees, reimbursement, visitation rights, during serious illness, etc. And go on and talk about diet services. This is what I was talking about during that admission policy. You got to let them know up front what's going on. Are they going to remember every bit of this? Are they going to understand all of it? No, and neither would we. I mean, it'd be like me at the end of today saying, okay, I want to have a quiz. I want everybody to tell me what the third line under admissions on the second screen said, what the fourth word was. There's no way. But are they given something? Is there some way for them to refer that they're going to be able to know? And then also, I don't think it hurts once residents have been in there, for if somebody, a family member or the resident says something, for you to say, well, that's not actually accurate. Do you remember when you first came in and we gave you some admission papers? Let me go over that with you again and show you this. That helps a lot. It refreshes. And then also you have people that are having some cognitive issues. I'm 51 and I can't remember what I did yesterday. So you've got somebody who's now in your personal care home who's 85. You know, it's going to be acceptable for them not to remember, you know, now how much am I paid to be here? These things happen. So, and then you've got, you know, a 25-year-old daughter who's like, well, I don't remember what did we say we were going to pay? You know, doesn't that include this? Or I thought, you know, you mean you're not going to take mom to the beauty shop? Those are things that, you know, you do need to have spelled out that you can have them referred back to. You know, these are our fees. This is what we charge. This is what we provide. And it continues on. They get a complete medical evaluation, including medical history, physical exam, diagnosis. Now, this can be a copy of a discharge summary, okay? If they have been or seen a physician, been in a hospital within 14 days prior. So, and it's pretty clear, 14 days. It doesn't say working days. It doesn't say 15 days. So, and I know it seems a little harsh to say, come on, this is what I've got. She was in the hospital 15 days before we admitted her. The regulations say 14. It's got to be 14, okay? And the definition of a day is 24 hours, so let's just, you know, instead of arguing, just go by 14 days. Some residents, not going to have an issue with. Some, you're going to like, missed it by day. Got to make sure you get this done. Okay. Patient rights, which we're going to talk about later in the afternoon. But basically, patient rights have to be provided according to the law. And then in the books you've been given with regulations, they talk about laws also. You can refer to that. So each patient needs to have these. And you've got to be able to show us how, you got to be able to prove to me that they each got one of these. Because I'll guarantee you, if I go to your residence and say, did you get a copy of the patient rights when you're admitted? The majority of people aren't even going to know what I'm talking about. Now, you may have some, because, you know, I've actually interviewed people in a personal care home. They were an attorney, and they were like, oh, you're talking about KRS, blah, blah, blah. Well, that's one. But a lot of people aren't even going to know, well, they gave me some stuff. So it's going to be up to you to be able to show me. And this is our admission process. This is what we give. This is how we give it. We have them sign this to show they received a copy of this, 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 and this. That's what I need. I'm not going to go quiz the resident on, can you tell me about patient rights related to what that says? Because, you know, that's, as long as we know that they got a copy of that, their responsible party got a copy of it, etc. It's provided upon admission. You may have questions about that?
I want us to take a step back at P0083, and I really want us to dissect this a little bit. A lot of times when you all are, when personal care homes are doing admissions, what we're finding across the state is that this whole aspect of the medical evaluation isn't necessarily being done in a thorough manner. We recently issued a Type A citation in a facility where they had a medical evaluation. It was very brief. The day after they admitted the person, they found out they got a discharge summary from the hospital that they had been in that specified that this resident had violent tendencies. Those violent tendencies included a history of attempting to choke his mother, to try to kill her. With that information, that facility, all they did was they told their staff that they need to watch that resident. They didn't do anything else. One aspect that we really want everybody to be cognizant of is when you admit a resident, as Jerry has told you multiple times today, you're taking on the responsibility that you can care for that person. You're saying, yes, we can meet their needs, and we can also provide protection to all the other residents within our facility. It is very important for you to know on the front end, prior to actually doing that admission, what that person's history is. Do they have violent tendencies? Are they a sex offender? Do they have a background that maybe your staff can't provide care for? Or if they come in with mental diagnoses, do your staff have the ability to care for them? Have they been trained on how to deal with someone who has schizoaffective disorder? Have you provided them with that kind of training on how to deal with those behaviors? We have many facilities that are personal care homes now that have multiple residents in the facility who have mental retardation and some other kind of mental diagnosis that makes them very difficult to deal with. And we're seeing that across the state more and more in our personal care homes. And what needs to happen in regards to this medical evaluation, and key point here is medical history and physical examination and diagnoses. When you admit that resident, that day that you admit them, you are saying you can care for them and that your staff can meet their needs. So when you're aware, when you become aware, even if you didn't know prior to admission that this person had violent tendencies, and then the next day you find out after you've admitted them, you immediately need to start establishing how you're going to meet that resident's needs once you become aware. Assessing that resident, finding out what kind of assistance, what kind of training your staff would need. Not just we need to watch the resident. Unfortunately, there was a negative outcome that happened with that particular case. That particular case, that resident became violent towards a staff member. And the staff member, luckily, well, it wasn't lucky, another personal care home resident interceded and protected that staff member. That resident ended up being harmed. 2 other residents within the facility interceded and had to physically hold down the violent resident, who then they had to contact the police to get this handled because of violent tendencies. So what we would like to happen is that personal care home administration, whoever does assessments, determinations as to whether somebody is appropriate to come to their facility and to be a part of their community, that they take into consideration medical history, what these people are capable of doing. Because once you admit them, you are saying you can provide that care. You're saying that you are going to make sure that your staff are trained to provide care to them. Another aspect is just calling 911 as a means of dealing with someone's behavior is not the answer. Your staff have to know how to deal with those behaviors. The first step that an administration can do in a personal care home is finding out the information prior to admission on what you're going to have to provide for that particular resident, especially when you have someone who's been adjudicated incompetent. If you find out that they have a state guardian, you would want to ensure for the safety of your current residents and to assure the safety of your community that you have the ability to care for those persons that you're admitting. What is that person's history? If they've been adjudicated incompetent, what does that mean for that individual? Are they just adjudicated incompetent for financial standpoint, or is it total incompetence? And that is up to that facility to identify what kind of care and services you're going to have to provide for them. When they're admitted adjudicated incompetent and they have a history of wandering out of the facility, And you need to find out as an administrator, is this person able to leave our building without supervision, even though they've been adjudicated incompetent? Or is this somebody that we will have to provide supervision to if they leave our building? And that is something that your facility has to be aware of prior to admitting, so you know if that person is capable of leaving your facility, if they've been adjudicated incompetent, how they're adjudicated incompetent, what kind of medical diagnoses are they bringing into your complement of residents, and how to care for those people. I just think that this is a very important aspect that sometimes in some of our personal care homes across the state, that they're really not doing a thorough assessment to identify if your staff is capable of caring for these individuals, and if training has been provided to ensure that they are capable of taking care of those individuals.
Well, one of the things that came up that I think is something, it's a good question, and I think it's a good question to ask yourself. Right off the bat, how many facilities, you don't have to answer, have ever had a staff member's child come to the facility? Or ever had a daycare group come and visit? Or ever had a resident's grandchildren or nieces or nephews that are minors come to your facility? So if you've had that, and you've admitted someone that may have been convicted of and is on the sex offender register for abusing a child, it's one of the things you have to think about. And once again, remember the thing I got told by my dad: just because you're old or just because you're infirm doesn't mean you're nice. Doesn't mean that you haven't had issues. So you are responsible for the residents there. You're also responsible for your staff. Now, we don't get into that so much. You also have a responsibility to the community. So those are things that very much could affect what's going on in your facility. So doing a thorough intake. Now with that, I'm going to back up and I'm going to be a provider for a little while. I do, and I have an excellent assessment tool, and we use this assessment tool with every single resident, and it's a very thorough assessment tool, and we contact everybody we can. Well, the daughter lied. And she didn't tell you about Uncle Sam's activities and about his criminal history and about, because she knows that nobody's going to take him. So I'm just not going to tell him. He's sweet. He doesn't give me any problems. He's, that was back then. That doesn't happen anymore. Or the guardian, and I'm be careful here because I'm still a state employee, but the guardian may leave out pertinent things. Or, and it could be maybe the guardian got this person put on them last night and they got to find a place for it. They haven't even really looked at their record. It's still going to fall back to the facility because you accepted this person in your facility to provide care. So that means that person, you have to meet their needs, and you have to meet the needs of everyone else. You have to protect them, and you have to protect everyone else in your facility. So there are going to be times when all of a sudden now you get this information. It's not fun, and I understand that, because now you're like, whoa, we had no idea this. Now all of a sudden he's attacking people. We have vulnerable residents, and this is something to let you know too. Just because someone may have been a sex offender having to do with children, and I don't mean to be an expert on this, I'm not. But my understanding is that a perpetrator who does this sort of thing, it's not necessarily just children. It's vulnerable adults. I've seen personal care homes where residents were unable to stand trial because they were adjudicated incompetent and mentally incompetent to stand trial, even though they committed some pretty heinous acts. Were sent from one facility to another thinking, well, we're going to go to this facility because this facility maybe doesn't have females. And then all they did was they perpetrated on vulnerable males in that facility. So be careful of your thinking here. Someone who's violent is probably not going to be violent just to this set of group of people. Their thought processes aren't that specific. Perpetrators who commit sexual crimes or sexual assaults can change. For 10 years, this is the only type of person they went after. Well, today they went after this one. So don't get comfortable with thinking, oh, well, this was just for children. We don't have children here. You have a school down the block. You have somebody's grandchild coming in to visit. So be aware of that. Once you find out that this person has this person's, these are needs this person has, then you've got to find a way to meet those needs. Your staff have to be trained. You have to follow through. You have to make some tough decisions sometimes. Can we meet this person's needs? But just because you find out something you didn't know, it's not an excuse to automatically discharge either. Now, that gets real gray area. You have to be careful because you can't just start discharging people left and right without, there are discharge regulations and you have to be able to meet those. Okay? So, but I think it's very important what Samantha said, and I want to reiterate that. That assessment is the most important part. And I have found that lots of times facilities will fall down on that initial assessment. That people will contact them, my aunt is this old, she needs this kind of help, she can do this, she can do that. Sure, fine, we'll take her, bring her on in. And then all of a sudden, now you've got a huge problem. So be very careful, make sure your assessments are done well, that you know the people you're getting, as much as you can. I mean, like I said, people don't tell you the truth. Because, with some of this stuff, we've gone back when we've done investigations, and people have told us, well, no, I didn't tell them that. Well, did they ask you? Well, they kind of asked me. Well, how do you kind of ask if somebody's violent? I mean, so, and well, no, I forgot to mention that, he tried to strangle his mother. So those are things that people will lie to you. I find that lots of times very honest people sometimes will hedge on stuff when placed between a rock and a hard place. And I understand where they're coming from. They can't care for Uncle Sam, but they can't get anybody else to take it. So maybe we just won't tell the truth. I don't agree with it. So,
yes, you're exactly right. She said other facilities do that to you, where they're trying to get rid of a troubled, right? Where they're trying to get rid of a troubled resident because they can't meet their needs and they may not leave everything. Right. How many of you all, when you're conducting a pre-admission screen, how many actually do a pre-admission screening prior to bringing them in? Raise your hand. That's good. How many of you actually go on site to wherever they're located at?
If it's convenient.
If it's convenient. Some of them are miles away. Would it benefit you, even if they're miles away, to go and see how they're reacting? How are they working in that facility? And they might not even be in a nursing facility. They might not be in their home. How many are being contacted by the Department of Corrections because they're being placed out of they finally did their time? Have you all had any calls? No? There's a whole bunch of personal care homes that are actually admitting persons who have served their time and going straight from serving their time who require care in personal care homes and going straight to personal care homes. Is it wrong? What do you think? You think it's wrong to admit someone like that? Yes, no?
I'm 80 years old. I've committed 3 murders. I've served 60 years in prison. I was 20 when I did this. My sentence is up. My sentence is up. But I can't care for myself. I may be mobile, ambulatory, but I need personal assistance.
I think it's okay.
So the Department of Corrections has said, I've served my time. I've paid my debt to society. Now, I have a personal opinion about that. How do you pay for taking somebody's life? But that's the system we have, okay?
Personal care.
So now we're going to go take me to a personal care home. I may not cause you one bit of problems. Or just because I'm 80, just because I've been in prison 60 years, I may be a monster. So those are things that the facility needs to say, and you may be equipped to handle me as a monster. Okay? But you may not be. It's very important that you know that up front before you say, yes, let's bring Jerry in here. So, and even then, you can do your very best and still not get accurate information. Just be aware of that. Okay? So, just want everybody to make sure that with those assessments, the other thing I want to bring up while we're I'm not going to touch that. I'll blow it up. One of the things I want to talk about is if you have a resident that is showing a behavior they've not shown before. You've talked to the physician. It's decided we need to maybe have them go to the hospital, have some assessments, look at what's going on, maybe review medications or whatever. So they're being very violent and doing all kinds of things. They go to the hospital. The hospital calls you back 2 days later and says, "Oh, they're fine. Everything's great. Come get them. They're ready to come back." You can go to the hospital. You can go in, talk to the person, and see. And I've had people call me up and say, "You know what? The hospital tried to send them back, and I got there, and they tried to get out of bed. They were going to come after me. They're not ready to come back to my personal care home." That's appropriate. The other thing that happens a lot of times, a hospital stay may be wonderful for them. They may really like it. So they may calm down. Maybe medications have been adjusted, but very few of these medications take effect within 3 days. So they come back to your facility and you start right back up. So I recognize we know that kind of stuff happens to personal care homes. So it's not like we're expecting it. It's not all black and white. It's all not, everything's going to be perfect. You're not doing your job. If you're doing your job, this doesn't happen. I understand that. Just make sure that you can show we've done reasonable things. We've done everything we possibly can do at this point to make sure this person's healthcare needs are being met. Once again, remember those simple answers about, well, he refused to take his medication, or he's just dangerous, we're going to get rid of him. There's got to be more to it.
And the other issue to add on to his behavioral issues, because we know Jerry has behaviors. If they are in the hospital and you do go and you do monitor to see how they are responding, they come back to your facility and then the behaviors strike again. Have you actually spoken to the hospital to find out what they actually did, what worked for them, why they were so appropriate in the hospital versus what happens when they come back to the facility? Because sometimes that kind of communication, or do you just go based on, well, we got these doctor's orders and we got this discharge summary? Take that extra step. Find out what they did. Now, if they just knock them out with medications, you certainly, unless you have physician's orders, don't want to knock them out with medications, but you want to look into what can we provide to monitor and to decrease these behaviors that are causing the problems. There's usually a causal factor.
And be very aware that every time that, as a personal care home, you call in and say, "Jerry, I'm calling to let you know that XYZ hospital is," I don't know what they're doing up there, but they said this resident's ready to come back. They came back, they're a wild man, or they came back and they're so drugged out they don't even know what they're doing. Well, I probably have already received a call from XYZ hospital saying, "This personal care home is the most neglectful place I've ever seen." Blah, 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 blah. Both of you they're doing acute care. You're doing long-term care. They hold hands, but they're not the same. So what I tell the hospital is, can you give me information that you've received of what was going on with that patient at that personal care home in the prior months before they were admitted to the hospital? Well, they can't. So they really don't know. It's just some assumptions and some guesswork. And a lot of times, unfortunately, on the personal care home side, it's the same thing. Really and truly, just because something's not working doesn't mean they didn't do their job. But at the same time, by going to that hospital, doing that assessment, you can make the determination that person's not ready to come back. We're not dumping them on you to the hospital. We're telling you they're not appropriate to come back to us. We will take them back when you can show us that they are. And part of that would be that they're not trying to get out of bed and strangle me. So, and those are things you can let the hospital know. And it's, I've had actual personal care home staff say that I had the nurse with me from the hospital when this resident was cursing and screaming and saying, "I'm going to kill you." Well, then how does that hospital staff then say, "Oh, yeah, they're ready to come back"? Now, the hospital can say, and they do say, and I've had a psychiatrist say, this is the best it's ever going to get. This person, it doesn't get any better than this. This person is violent, they're angry, short of knocking them out with medications, drugging them, restraining them with medications. this is the best it's ever going to get. That's when the personal care home has to say, we need to assess this individual. Are they appropriate for our personal care home? So I'm not saying you can't ever discharge somebody, but you can't use discharge as a means of taking care of your staff. Or, well, that's too expensive, we can't do that, we'll discharge them. So it has to be truly meet the definitions of transfer and discharge, okay? So be very careful about those discharges, because they can ask for a hearing, and if you don't prove it to the administrative law judge, you'll lose the hearing.
And another aspect that's important, because right after this slide, he discusses patient rights, and then it goes straight into transfer discharge. And we'll later talk about the patient rights reg. This is your opportunity as a personal care home upon admission to lay the foundation, the groundwork of what your policies and procedures are as it relates to the care of the individuals that you're providing and what you are able to provide that works within your scope of practice as a licensed personal care home. So this is also the opportunity for you to say, this is what a licensed personal care home can offer. This is the type of person. This is what your loved one has to be able to do for themselves. This is all the assistance that our personal care home can provide. As your loved one progresses through the aging process, certain things are going to decline. And as we go through that, we will be assessing on a regular basis these residents. And we're going to be coming back to you when we've identified that they are getting very close to exceeding our scope of service and what we can actually legally provide. At admission, you lay the groundwork to inform those families. Because a lot of people, especially, how many of you all are in the plush personal care homes? Raise your hand. Well, it's beautiful, right? It's like the Taj Mahal. People don't want to leave. They want to just admit their residents into these beautiful homes, and that's where they want mom to die. They want her to be there forever.
And you're going to hear, now wait a minute. I brought my mom here, Miss Samantha, and you said you could take care of her. And now you're telling me you want to put her out? I'm talking to the state. I'm not putting up with this. I paid good money for her to come here, and now you're telling me she can't be here. Because there's a little problem. I've got your game. I know what's going on. And then I get a call.
No, I'm the one who gets the call.
And she calls me. But it happens
It
a
does
lot of
happen.
times. Now, sometimes you may have explained every bit of that. But lots of times, it hasn't been explained.
And it's not just about upon admission explaining that. It's throughout. As your staff communicates to you, you communicate to your families, because that communication is integral for you to make sure that any kind of transfer and discharge, which we're getting ready to go through those regs, that helps you to make sure that you're meeting those requirements. When you've met with the family and you've said, okay, right now there's been no changes in what Jerry's abilities to assist himself in the requirements of a personal care home. But then 3 months later, we've noticed that, well, we're providing a little more assistance to Jerry when it comes to bathing and going to the bathroom. He's starting to experience some incontinence, but he knows when he has had an incontinent episode, not incontinence. Those two. So that way, as you progress in discussing the progression of this person's disease processes and declines in their aging process, you're lining it out. You're letting them know they're getting closer to where they're going to exceed what we can offer. How many of you are doing that right now in your facilities? Well, if you're not, I strongly recommend that you consider doing that. I can't tell you what to do. Okay, I can tell you that these are the regs that our surveyors are going to be looking at when they come to do your standard licensure survey and complaint investigations. And we do. When we get requests for or complaints on discharge and transfer, we come out and we look at that. And we're going to ask you to show us evidence And we're gonna interview the family. And we're gonna interview the resident. We're gonna interview your staff. We're gonna interview you as the administrator or you as the director of nursing if you are a director of nursing. So this will help you along the way if you have that communication with the family on the front end and throughout as the disease processes occur, as the resident continues to age, and their abilities start to decline.
The majority, and this is a true statement, the majority of people that are in personal care home will not end up in personal care home. As Samantha said, the aging process, the disease process, family needs to be made aware of that up front. There will be occasions when Mrs. Smith didn't wake up this morning, that it was sudden, nobody expected it. That's going to happen. But the majority of people will decline to the point where they no longer meet those definitions. So you have to ask yourself, not just upon admission, but like Samantha said, I want to reiterate that upon admission, are they ambulatory, are they non-ambulatory, but they're mobile ambulatory? Are they able to take care of their most of their activities of daily living? Upon admission, they are. Maybe they've been in your facility 5 years and they still are. That's wonderful. Maybe they've been in your facility 6 months and they've declined to the point now where most of the activities of daily living they can't complete. That should not be a surprise to the family. There shouldn't be a phone call from you saying, oh, we need to let you know we're issuing you a discharge notice. Your mother she no longer meets. The family shouldn't be like, what? What do you mean? That should be something that should be given to them or provided to them during this process. You know, and I'm not saying there's nothing that says you have to have a meeting every quarter or you have to do this, you have to do that. They do talk about care plans, and we'll talk about that later on. And those aren't really detailed like they are in skilled or like in certified facilities. But that is an opportunity for the facility to give that information to families. We've noticed that your mom is requiring more and more assistance with things like bathing and dressing, and her confusion is getting more and more. We just want to make you aware that right now she's still okay, but she is approaching that gray area. Or your mom has the flu, and because of her illness, she's in a weakened state. We expect her to improve, but we want to let you know she's right on the line right now. With improvement, she'll be okay. Well, this is what we've done. This is what we've documented. This is what we're doing. We're assessing her maybe weekly, daily, whatever it is, so that we can make sure that we can say she belongs in personal care. But it's very possible she may not. So we want to let you know so you can start looking. And maybe our social worker or we have a sister facility or whatever that will put you in contact with. And then if she improves, then you let the daughter know. Or, like I said, as people decline, you can start to say, this is what's going on. So it shouldn't be a big surprise to anybody. It shouldn't be that phone call one day where I open the mail and, well, they've discharged you. So that's one of the things that's very important that the facility keep on top of. Because if you're providing adequate supervision and you're meeting their healthcare needs, it's not a surprise to you. Your staff know it all the time. And if staff are communicating, that's my big word, communicate. Because I think without communication, that's the root of all evil in my world. So it comes to communicating. It's usually almost every complaint, literally 99% of the complaints I get is because there's been poor communication. And even if the facility dropped the ball on something, usually I get the complaint from the family because there was no communication to explain, you know what, we didn't do that, or we didn't get that doctor's order transcribed. We didn't get the medication started, but this is what we've done. We want to let you know we apologize for that. We've taken care of it. This is what's happening now. She's got her medication. We talked to the physician. There's no outcome. We want you to know your mom's safety is paramount to us. But instead, they get, oh, those things happen. Well, let me tell you, they got my number on speed dial. And that's so lots of times communication, it's almost always about communication. It truly is. So sometimes it's about you fired me and I'm going to cause you all kinds of problems, or you discharged me and I'm, there's always those issues. But usually it has to do with communication. So moving on. Well, let's try to continue on it at mission. We're talking about these policies have to be in writing. They have to be the family or the relatives or the responsible party has to be informed in writing. And they have these things include, but they're not limited to, and I always think more is better. Of course, your legal staff or counsel may not believe that. They may think more is better. I mean, less is better. But I think when you're talking about getting this information to families, it needs to be very clear, very concise, and it is a regulatory requirement. We talk about fees, reimbursement, and that's very important. Somebody pays you the first of the month and they're there 3 days. What's your facility's policy on reimbursement? And how does that happen? So they call me and they say, yes, Mom was there for 3 days in July and we haven't received any reimbursement. So I ask them, do you have a copy of what you were given upon admission? And lots of times the facility is not following their own policy. So be very careful that you're aware of what your own policies are and what you're providing to people, because let me tell you, they may not remember much, but they'll remember the fee and the reimbursement policy. And they can probably cite it, and I'm the same way. Don't mess with my money. So just remember that. Also, visitation rights during serious illness. Most facilities have an open door policy. But if you've got an epidemic going through your facility, you need to have, because you're protecting the general public, or right now, you've got the school down the road from you has an outbreak of the swine flu. You may need to say, okay, maybe we don't have serious illness in the facility, but we do in the community. Do we want to invite it in to our vulnerable population? Now, I'm not saying put bars on the doors and yellow sticky and say, have people with guns posted at the door, but you need to have a policy to let you know, to let the general public know what's going on. And you may ask them, we're asking you that at this point, if you have a cold, if you've had a cold or the sniffles or any of these signs, could you please curtail your visits? Could you not come? If there's someone in your home with the flu, would you please not come until you got the clear from the doctor? Those are reasonable requests. Now, you can't tell a resident you can't have a visitor. So you've got to meet their rights. But I think those are very reasonable things to do in a personal care home. And once again, you'll hear me use that word a lot, reasonable. Anyway, we talked about medical evaluations and discharge, patient rights. We'll talk about quickly about written policies that talk about, these are laws. This regulation is talking about laws, okay? We're talking about KRS 209, which is state law. It talks about protection of adults, vulnerable adults, and reporting requirements. And then also 620, KRS 620, is the same sort of required laws having to do with children. And here's the thing, the facility is required to have policies on both, and that your staff are aware of what those are. And I think this is going to be the last screen we talk before we do a break. But one of the things I want to talk to you about is, remember it talked about 16 years or older? So let's say you have a 17-year-old, which I've never actually seen someone 17 in a personal care home, but it is possible. So therefore, that you have a child in your facility. Okay? So the requirement is you have to know this. You have to understand the law. You have to know the reporting requirements. Here's one of the things that I go into a facility and I interview. And I ask somebody, a staff member, can you tell me what your policies are about reporting? And the staff says, oh, well, I would tell the administrator. So I'm going to go straight to you and I'm going to tell you, I think Samantha has abused somebody. Okay? Okay, well, that's good. I'm glad that you know that you have to report any suspicions or any things you see that you think are allegations or that you think are observations of abuse. Now, let me ask you, what if I ask the staff member, and I say, well, then tell me, what if it's the administrator that you think is being abusive? And I get these blank stares. So that's not making sure that your staff are aware of the policies and how to report. If everything is coming through you, and then I ask them, what if you think it's this person, and they don't know what to do? They don't know. And if they don't report it, the law says they can be charged with a Class B misdemeanor. And it happens, and I've seen it happen. So your staff have to know. Now, what I love is when the staff says, oh, well, if I thought the administrator was abusive, in our break room, there's a big number up there. It's for, I think, adult protective services or child protective services or something, but it's a big 800 number. We just called that. And I've even gone home before because I didn't think they took me serious and called it. Excellent. Now, I encourage your staff to notify the administration because the administration is going to have to do something immediately to protect all residents. So it's not like I'm telling them, oh, sneak out and call somebody, but you need to be telling them that they are responsible by law to make sure that it gets reported. You reported it to me. I will report it to the state. I will give them this information. This is what we're going to do. Telling them thanks, I appreciate it, and them sending it off, they don't know it got reported. So make sure that everybody in your facility understands what 209 and 620 require and that you understand it. This is something that I do a training for the Healthcare Association for new administrators and director of nurses. And it is amazing how many people that will come to that have actually been an administrator somewhere else or a director of nursing and don't understand that they have to have 620, that they have to have knowledge of that because that is the child abuse also. And we have copies of that in this manual also, so we have questions on that. But anyway, I think